communication tool, in this case, miscommunication tool, brought her to that conclusion. Also, we find some things in documentation that you probably want to have reread and said, maybe I need to rephrase. Dr. whatever his name is wants to sit on her abdomen. People take things literally when they read them. And that's why, we always explain to people what SOB means. It means shortness of breath. They don't get that. They don't understand our jargon and our language. Admission notes that are dated after the first progress note. So we're out of chronological order. This was a quote from the emergency department. She has no rigors or shaking chills. Her husband said she was very hot in bed last night. Patient has 2 teenage children, but no other abnormalities. And my personal favorite, large brown stool ambulating in the hall. Could use a little punctuation and maybe some capitalization. So legibility, when we talk about legibility of records anymore, with electronic health records, that helps a tremendous amount. We no longer have HMPs standing for horrible and profitable for plaintiff's attorneys, but they're actual HMPs, histories and physicals. So there can still be those opportunities to have handwritten things in the record. If you're completely electronic, you still could get some handwritten records from other facilities that are scanned into your record then. So there's still an opportunity to see some of that. And there's also a new threat to some clear mutual understanding of what something means. And that involves technology that we use every day. So pharmacist received an order for Slomax, 64 milligrams TID today. So how many times a day is she to get it?
3 times.
3 times. And how many days?
Today. 2 days for 2 days.
1 day.
Day.
Okay. Pharmacist who got this went, I wonder if the resident that ordered this meant just today or for 2 days. So she called the resident, and the resident said, oh, it's texting. It's texting shorthand. So, yeah, don't use texting shorthand. It's not an approved abbreviation. 2 day is not an approved abbreviation. So you can't drift into bringing your texting life into your professional life. Fortunately, that one, that was one that was found. It was a near miss, so it was an opportunity to learn and tell everybody, woo, don't do that. Rather than just telling the one resident, they did inform everybody. So objective documentation, you're going to avoid reporting staffing problems. You're going to keep staff conflicts, rivalries, whether it be physician to physician, physician to nurse, nurse to physician, nurse to nurse, out of the record. You're going to steer clear of words that are associated with errors. I inadvertently, I mistakenly, I in error did, blah, blah, blah. Just state the facts. You don't have to use the extra words for it. It's, if I gave Demerol 50 instead of Demerol 25, Demerol 50, I am given where, how, when, Dr. Smith notified of Demerol 50 given, no orders received. Doesn't sound like an error, does it? But it states the facts. It states the facts that I actually gave 25 more milligrams than I probably should have. Avoid bias against the patient. Derogatory comments, patient is a non-drug user, please call, anything like that, and never assume anything. Always be very factual. The bottom line is if it's not about or pertinent to the patient's assessment or treatment, it doesn't belong in the medical record of that patient. So, keeping it's sanitized of those sorts of things. Jousting is where it used to be, you got up on horses and you poked at each other with big long sticks, right? And we've all been in the Renaissance fair. But jousting in healthcare has almost become epidemic. And a lot of facilities are doing everything they can to stamp it out. It is where we have a rivalry or problem with a coworker on the healthcare team, and that could be doctor, physical therapist, lab tech, anybody against anybody. It can be verbal. It can be inadvertent. If you refer a patient to a tertiary care center, for instance, maybe that patient's had an open coli with a lovely scar. And, most of them are closed anymore with the, thank you. And so, you don't see those scars as much as you used to. But so somebody younger may, take, it may just be their gesture of, whoa, when they look at that. And the patient's keen on that. They're looking at it going, why are you reacting like that? The person examining them may even say, wow, who did this to you? Sounds like maybe that shouldn't have happened. Maybe I need to get a copy of my medical records. Maybe I need to consult an attorney. Maybe I need to get a second opinion of maybe this shouldn't have happened to me. So we see it in a lot of different ways. In the medical record, it looks like this. Nurse is reprimanded for error. Again, there's the error word plus reprimanded. If it doesn't pertain to the patient's assessment and care, it doesn't belong in the medical record. That will be your mantra when you leave the room. This incompetent consult has cost the patient hundreds of dollars and does him no good whatsoever. Dr. White was paged repeatedly and ignored us per usual, despite the best, and you may have paged Dr. White lots of times, but it's at 8:36 p.m. Dr. White paged. 8:40, Dr. White paged. Eventually, after you've listed that, however many times you can possibly tolerate it, or is good for the patient, you're going to activate your chain of command. You're going to go find some other way to get in touch with a care practitioner who can help you with your dilemma or the patient's needs. Despite the best efforts of the patient, despite the best efforts of the nurses, the patient survived, barely. Not a glowing report. One other one we also saw was, and I mentioned don't take staffing issues in. Nice nurse, night shift, didn't get meds delivered on time, knew she was going to get, dinged on that. Because this, and she wrote this in a patient's medical record, because this hospital does not value the safety of the patients enough to hire sufficient nurses. I mean, it went on for like days, and it was the most painful thing to read in the world. I was unable to, deliver patients' medications on time and putting their safety at risk. I mean, if you have an issue with administration, you work through administration. Working through the patient's records, no way to do that. Timely documentation, we always like to have you strive for real-time documentation. There's no time like the present. Again, I spoke to earlier, you can get remote access. So if someone's accessing that remotely to see what the current condition of their patient is and whether or not they need to order anything additional for them or cut back on a medication, they're going to want as much real-time information. So saving everything for the end of an 8 or, for goodness sake, a 12-hour shift isn't going to be timely enough. So, also we're going to talk a little bit about alterations. This was a sad case. So an 11-year-old boy was being treated by specialists long-term for developmental problems and also chronic constipation. He was brought into the emergency department in acute distress, weighing about 45 pounds. So you can picture that this young man was in a great deal of need. His limbs were spindly, his belly grossly swollen, his eyes sunken, and he died during the treatment in the emergency department. An investigation into his death was launched. The patient blamed the outpatient physicians for poor treatment that led up to this emergency department visit. The physicians, however, stated that the parents were non-compliant, frequently missed tests and appointments. The boy's parents were indicted by a grand jury and charged with child endangerment. The parents, in turn, filed a malpractice claim against the physicians alleging improper treatment. Medical records were subpoenaed by the county attorney almost immediately, who was investigating the child abuse allegations. Several weeks later, the malpractice attorney requested and received copies of the boy's records. Now, anytime you issue medical records, they go to both parties. So now this county attorney has the 2 weeks old medical record. This comes into play because the copies obtained by the malpractice attorney contained numerous entries of missed appointments and documentation of a phone call with the parents instructing them to immediately reschedule a very important appointment. These missed appointments and phone call documentations were not found in the copies that were obtained immediately by that county attorney. The malpractice attorney then brought 2 sets of records, the one defending the parents, brought 2 sets of records to the court that did not match. One of the physicians had added the extra documentation after being served with notice of the malpractice claim. The physician testified that the alterations were made to not to mislead anyone, but to simply reflect the non-compliance of the parents. The attorney argued that the alteration of the record said something about the credibility of the individual who created and altered the records. The parents were acquitted. The malpractice claim was closed with a payment to the parents due to difficulty defending the physicians, and the Board of Medicine also fined the physician for altering the records after the fact. So we'll talk about alterations in late documentation here and what the impact is sometimes for that. If you have documented and you know that you went to bed the next night and you're like, oh, I forgot to document something really important, it's okay to add an addendum the next day you go in. If you go on vacation for 2 weeks and come back and then add that documentation, it's a little suspect. I would just say 24 hours, 48 hours, maybe, and know your documentation policies. It may be expressly said for you how long it can be before you need to add that addendum or late entry. If it's older than a week, though, sometimes it's best to start it with, this is my best recollection of, for the entry dated this date, this time. It can certainly be appropriate if notes were forgotten to be added, as I mentioned, or if additional information, if your colleague says, oh, hey, read your note from last night, you might, did you forget to document something about their, let's pick something. Okay, their circ checks after they're casted, or their wound site, is it reddened, is it not reddened? But if there's something that you documented that is unclear, it's okay to put in an addendum. You always want to make sure that you note that it's a late entry or addendum. You reference the entry for which it was written and what it applies to. And there's really no time limit unless it's expressly said in your policies or procedures. From our standpoint, there's not a horrible, red line in the sand that you don't want to cross. But you never want to add a late entry or an addendum when there's already been an untoward outcome. I'll give you an example. Patient comes to the emergency department inebriated, has fallen down, hit his head, he's bleeding, he's bruised. They clean him up, he's a little uncooperative, he refuses a CAT scan. So they're like, okay, and later he's belligerent and he's like, I want out of here, he's gonna leave. They get him to sign the AMA form. Well, there's very little documentation that, just as you wouldn't expect a person who's inebriated to sign a consent form, an informed consent form to have an appendectomy, the converse is true. You don't have them sign an informed refusal or an informed AMA. You document the circumstances under which they left and the best advice that you gave them. But that really wasn't in their record until the next day when they got a phone call in the afternoon that he had died at home. And then they went back and they said, maybe we need to beef that up. So similar to the specialists that were seeing the 11-year-old boy, they were like, okay, well, we need to beef that up now. But after you enter it as a late entry like that, and you can tell by the metadata, you can't fake it, it looks like a CYA maneuver, if you know what I mean by that, covering your patootie. So best not to do that after there's been a bad outcome. If you just can't keep your fingers off the keyboard or the pen to do that, work through administration, circle the wagons on it to me. I can ask our attorneys once in the history that I can ever remember in the last 8 years, have we ever had an attorney say, yeah, in that instance it probably would be best, if they do that. Now I also get the question of, well, but if we worked on this patient in the ED and then they died, is it a late entry to then go in and document within the hour afterward? No, that's just catching up. That's really normal process for you. But documenting it, 2 weeks later after they've died or 48 hours later, and you're beefing it up because they died, that's what it looks like. And documenting special circumstances. We're all going to have these difficult patients. I've been ringing and ringing for a nurse. I could have died before you got here. What kind of a hospital is this anyway? So you get these unhappy patients, and they interfere with your HCAHPS scores and everything else, and constant grumpiness, endless complaints, no response to friendly remarks. You do need to acknowledge the situation. You know, you seem angry, you seem upset. Would you like to talk about what's bothering you? Try not to argue with them. It's okay if the issue is pertinent to their care, their situation, their assessment, you can put it in the medical record. If it's not, and they're just being belligerent, you don't want to drift into a documentation habit of labeling them or having some sort of a bias or quoting them just because they said something horribly nasty and that sort of thing. It's okay to quote patients when they say something, you know, I have no intention of following the doctor's instructions to take, you know, my temperature, that sort of thing, post-operatively. If there are quality of care concerns, medical staff concerns, incidents, a threat of legal action, refusals of treatment, now refusals of treatment, again, that impacts their overall well-being. That could be pertinent to put in there. But those other things all need to really probably drift up through administrative angles. So you don't want to document in a patient's record that you called your attorney and you called and talked to the malpractice carrier, that you discussed them at a staff meeting or over dinner with colleagues. It's okay to talk about a patient in a care conference setting and document about that. We've seen, I smell a lawsuit in quotes more than once. Derogatory or inflammatory statements about the patient, and you don't, when you fill out an incident report, remember I said you just put the factual information. There's been a med error, that sort of thing, just the facts. You can put everything you want in an incident report, but you don't put the incident report has been completed in the medical record. The incident report is your quality, your correction of any problems. That's your avenue to do those things. It's not pertinent to the patient's care or assessment. And so, to close this loop up, some strategies for quality documentation. Make sure that you verify that the patient you're entering in is on the right patient. Sometimes reading the previous documentation will help you with that. Sometimes reading the previous documentation also helps you know, oh, I need to make sure, that I address for continuity of care issues this particular problem or issue that they have going on. You want to cultivate consistent, timely documentation habits so that you're not holding things back for 8 to 12 hours. Be very specific about your documentation. Be specific about the patient. Yes, I filled out the checklist, and yes, I got the data nuggets that everybody wants, but did it tell the whole picture? Is there something that I need to elaborate on? And don't be afraid to put that in your narrative piece as well. Follow policy whenever you're correcting or adding late entries, clarifications, or addendums. Never joust, and be on the lookout and help other people. I mean, jousting can be a drifted thing. They may not realize they're doing it and what harm it can do, so help others understand that. Some strategies for improving: make sure that you've developed, implement, and know your documentation policy. If you've worked here a long time, you might not have looked at it for a while, so it's a good time to review that. Templates, forms, if there are things that need to be corrected in either the policy, the templates, the forms, or if you need additional training. That's kind of why we're here today, to just kind of refresh it, bring it top of mind for you. Auditing documentation, I know Judy's been doing some of that. I forced my staff to audit each other's work. In a previous life, they didn't like it at first, but they grew to love it. They were like, I don't want to have to do that. I don't want to have to tell her that she's not doing it right if I find something. What they found more of that was actually, hey, I found some really neat things. I'm going to start to do it. This is a really good thing. So they helped each other do that. But you do want to post and review audit results. So find out how well you're doing. Find out where the problem gaps are. Work as a team to correct those. Be accountable to it. And I encourage you to speak up. If you've got things in your policy that are old, that you know, practice doesn't meet what administration said we were doing, sometimes happens. Or if there are templates or forms, things in your record that don't make sense and maybe we need to look at fixing it or changing it, speak up. And certainly celebrate successes where they happen. So if you think the effort involved in improvement in almost anything we do isn't worth it, do consider the cost of failure. Go back to, gosh, I want my good care to look like good care when it's reviewed in a medical record document 3 or 4 years from now or 5 years from now. The cost of failure otherwise is that we may not be able to completely defend you as well if there are gaps, if there are late entries, if there are incomplete information about a patient, if it's hard to say from the checklist exactly what was going on with that patient, or what was conveyed back and forth in our communication with each other. Call the provider, let them know the blood pressure is now this, the temperature is now this, not just there's been a change, or vague general information.